Good morning. I'm Nancy Frates. I'm the mother of a 33-year-old ALS patient, Peter Frates, who was diagnosed at age 27. Pete has been in a clinical trial, and just to talk about some of the things that were brought up. First of all, Brian, to whoever just sent that comment, and I look around this room, I was one of the people who spoke at that FDA meeting in February of 2013. So didn't my son. He still could speak at that point. I agree with the person who just wrote in, who said a lot of what we're talking about today, 6 years later, 5 years later, is exactly what was said in that meeting to the panel when 65 of us got up and spoke. In this disease, risk-benefit was so articulated that day by many people who are no longer here with us, who aren't here because they've passed. There was one gentleman who said, if I was on an airplane and someone told me I had a 1% survival if I jumped out of the plane without a parachute, or I could stay on the plane as an ALS patient, which one would I choose? And he said I would jump without the parachute because at least I had 1% chance. Unfortunately, 5 years later, we're still thinking in those terms. I'm wondering why the risk tolerance of a patient is not part of criteria, because I think that's a very, very important one. I think the 2-year, as Stephen, you so eloquently articulated, the 2-year cutoff from either symptom onset or diagnosis tends to be something that's just kind of thrown in there, where progression is so much more important. My son, after 2 years, was almost vented. So I think that's a very important piece. The other thing is, as Jane said, some of us who participate in these trials, as we're maybe further along in our progression, we're there for 8 hours. With these subjective measuring tools that we have, such as the FVC, even during that 8-hour period, when the FVC is done, can be a huge swing in what the outcome is going to be.
That's right.
So there are certain things that are they're just rational, simple things that can be done that are not thoughtful enough. So I applaud everybody who's in this room today, because let's talk about, just like Kelly said, the low-hanging fruit. Do the FVC as soon as the patient comes in the room, because after they sit there for an hour, it's going to be different. So I just encourage us to look at these thoughtful, compassionate things. And the other thing that I want to tell you is, in my 6 years in this disease community, I've been told a number of times, the clinical trial is not for the patients who were in the trial. But let me tell you, as the mother of a patient, we look for hope in any way that we can find. And when we're put in a clinical trial, even though we know that the real purpose of the trial is for the data, please remember that there are families and patients who are just looking for a little hope in this disease space. Thank you.